So my talk today will be on scaphoid fractures. I'll start off talking about the anatomy of the scaphoid and its blood supply, then go into the diagnosis and clinical and radiological evaluation, and also mention a bit about the classification of scaphoid fractures, and talk a bit about natural history and then the treatment. The scaphoid is the most commonly fractured carpal bone, and it's typically an injury of young adults, with or without an associating injury of the distal radius or the forearm. The importance of scaphoid fractures, which I'll expand in a moment, is that displaced fractures do have an increased risk of non-union or malunion, and that can alter carpal kinematics and end up with an arthritis of the carpus. To understand the significance of scaphoid fractures, I think we should talk about the anatomy and the importance of the anatomy of the scaphoid. I guess mainly for the medical students. The carpus consists of 8 bones. There's a proximal row and the distal row. In the proximal row, we have the scaphoid, the lunate, the triquetrum, and the distal row is a trapezium, trapezoid, the capitate, and the hamate. There's another bone here called the pisiform. That is actually a sesamoid bone, which is located in the tendon of flexor carpi ulnaris, and doesn't really contribute to any of the structural integrity of the proximal or distal rows. The proximal and the distal rows articulate with each other at the mid-carpal joint, and the proximal row at the radiocarpal joint, with the distal end of the radius. The scaphoid links the proximal and the distal rows, hence is important in its structural integrity. The name scaphoid comes from the Greek word scaphos, which means boat or ship, and some say that the scaphoid bone resembles the appearance of a boat. Others would argue that it looks more like a twisted peanut. The scaphoid bone, most of it is covered by articular cartilage, around 75% of it, and it articulates with the distal end of the radius, the lunate, the capitate, trapezium, and trapezoid. Because most of the scaphoid is covered by articular cartilage, there's only a few places where blood can actually enter the bone. On the dorsal surface, at the dorsal ridge, and the volar surface at the distal tubercle. Looking at this diagram, we can see the dorsal scaphoid branch enters on the dorsal ridge and has a retrograde flow from distal to proximal, supplying most of the scaphoid and the proximal pole. Whereas the volar branch inserts at the distal tubercle, which supplies only the very distal end of the scaphoid. Here there's a picture here of a contrast study, which again shows the same thing. The dorsal branch supplying most of the scaphoid bone, and the volar branch just the very distal end of the tubercle. There've been a few studies done in the past, or cadaver studies, which one of them done by Gebelman in 1980, again showed that the dorsal artery supplies around 70 to 80% of the proximal portion of the scaphoid, whereas the volar artery supplies only 20 to 30% of the distal tubercle. The importance of this, the importance of the tenuous blood supply to the scaphoid, is that if we have a fracture of the waist or the proximal pole of the scaphoid, we can see here from this diagram that it'll disrupt the blood supply to the proximal end of the scaphoid. Hence, a fracture in this position, it has an increased risk of non-union or osteonecrosis of the proximal end. So the more proximal the fracture, the longer the healing time, and also the greater the risk of non-union. And also the more proximal the fracture, the greater the risk of having avascular necrosis of the proximal end. And the diagram clearly displays why. Again, the blood supply will also dictate to some point what approach we take for surgery. The volar approach is regarded more safe because we're staying away from this dorsal artery that supplies most of the scaphoid. When diagnosing a scaphoid fracture, commonly we'll see someone that's fallen on an outstretched hand, where the mechanism is a hyperextension of the wrist with radial deviation. If we have someone that comes in with that history and they're complaining of pain, swelling, and also tenderness, we need to suspect that they've fractured their scaphoid. A few principles when diagnosing the scaphoid fractures. Again, as I said earlier, typically it's an injury of young adults, whereas the older we get, it's more common to have a distal radial fracture. When examining the patient, if we palpate in the anatomical snuff box, if we palpate at the distal scaphoid tuberosity, which is on the volar side, and also doing a scaphoid compression test may be useful. And finally, just remembering that the scaphoid has a complex anatomy and will need multiple views on the X-ray. A typical scaphoid series will include a PA and a lateral, an oblique view, and a view in ulnar deviation. Here are some X-rays, a PA, a lateral, an oblique, and one in ulnar deviation. Now, although X-rays are helpful in diagnosing scaphoid fractures, we need to understand that around 30% of the time they're non-diagnostic. So a patient might still have pain and tenderness in the snuff box, but an X-ray won't necessarily show a fracture at the initial presentation. If we're highly suspicious that the patient's fractured their scaphoid, traditionally we've placed the patients in a scaphoid cast and reviewed them around 10 days later in the clinic with repeat X-rays, and a small percentage of these follow-up X-rays will show a scaphoid fracture. However, this method does require patients to be immobilized for a period of time. Some of these patients won't actually have a fracture, hence immobilized unnecessarily. So a number of radiological investigations can be done. These have been the use of a bone scan, a CT scan, and an MRI scan. However, out of these, the MRI is the most sensitive and the most cost-effective, and that can be regarded as a gold standard for trying to get an early diagnosis of scaphoid fractures. CT scans are very useful for evaluating the fracture displacement. So if we're not sure on the plain films how much a scaphoid has been displaced, it's good to get a CT scan, and that'll give us a good overall picture on the fracture components and the relation to each other. I'll talk a bit about classification of scaphoid fractures. I'll use Herbert's classification, which I believe is the most commonly used. There are some other classification methods, but I won't mention them today. So with Herbert's classification, it takes into consideration fracture anatomy, fracture stability, and also the history of the fracture. In type A fractures, these are stable fractures. It's divided into A1 and A2. In A1, it's a fracture of the tubercle of the scaphoid, and in A2, it's a fracture of the scaphoid waist. However, it's an incomplete fracture, hence stable. And these fractures can usually be treated with cast immobilization. In type B fractures, these are all unstable fractures, and they range from B1 to B4, being a distal oblique, a complete fracture through the scaphoid waist. This one's complete, hence unstable. Fracture of the proximal pole, and also a fracture associated with a dislocation. In type C, it's delayed union, and type D is when there's established non-union, whether it being fibrous non-union or having a pseudoarthrosis in D2. Fracture instability can be measured by the amount of displacement in the fracture site. and also the measurement of a few angles, being the scapholunate angle, the radiolunate angle, and the lateral intra-scaphoid angle. With fracture displacement, if there's a fracture gap of more than 1 millimeter on any X-ray view, it can be regarded as displaced. The significance of this is that there's a high non-union rate, up to 90%. The scapholunate angle, this is normal, so if we take a line through the lunate and a line through the scaphoid, this angle here is the scapholunate angle. The normal angle is between 30 and 60 degrees. When the scaphoid fractures, the lunate tends to extend or rotate dorsally, hence opening up this angle. Hence, an angle of more than 60 degrees is regarded as abnormal. With the radiolunate angle, again a line through the distal end of the radius and the lunate, normal is 0. However, as the lunate extends in a scaphoid fracture, this angle increases, so more than 15 degrees is abnormal. Also, looking at the lateral intra-scaphoid angle, if we take a line here through the proximal pole of the scaphoid and a line through the distal pole, this angle in here normally should be around 30 degrees. More than 35 degrees means that this proximal pole has flexed, and the distal pole has flexed, and the proximal one has extended, hence increasing the angle. This is regarded as abnormal, more than 35 degrees, and is associated with a humpback deformity. So, with unstable scaphoid fractures, the stability of the intercalated proximal row is dependent on the integrity of the scaphoid. So when the scaphoid fractures, the lunate will tend to extend or dorsally rotate because of its attachments to the triquetrum, whereas the proximal pole of the scaphoid will flex, as is shown in this diagram here, because it rotates with the trapezium and the trapezoid. And the result of this is the humpback deformity, as is shown here. The significance of this is that it changes the carpal kinematics, and that can result in a loss of wrist motion, especially wrist extension. You can get carpal malalignment and the progression of radiocarpal arthritis. Scaphoid non-union, it can be defined by having X-ray signs of a fracture not being able to heal, or if union hasn't occurred for a period of up to 6 months. However, some scaphoid fractures do still unite after a period of 6 to 9 months, so this could be a bit tricky. Some natural history studies have been done. One done by Matt Bose and Gellerman in 1984 basically concluded that a displaced non-union had a high chance of developing arthritis, and they recommended surgery in patients that had a non-union. Again, another study done by Ruby in 1985 also showed that the non-union of the scaphoid will develop arthritis. Now, as the arthritis develops and becomes worse, we get something called SNAC for short, which is scaphoid non-union advanced collapse, which is a specific pattern of degenerative changes which are related to a non-union of a scaphoid fracture. That's divided into three stages. Stage 1 is an early stage where there's degenerative changes at the radial styloid. The radiolunate and the capitolunate joints are still preserved in stage 1. In stage 2, however, there's radioscaphoid arthrosis. And in stage 3, as well as radioscaphoid arthritis, well, there's a progression of that, and there's also mid-carpal arthritis, or pericapitate arthritis as well. The natural history of malunion. in summary, the greater deformity of the malunion, so the greater the loss of wrist motion, especially extension. So for a small amount of deformity, for example, 5 degrees of deformity, you'll lose 24 degrees of wrist extension. And there's also the greater risk of arthritis. Again, there have been studies looking at malunion, and again, this confirmed what I just said, that malunion was associated with decreased range of motion and where wrist extension was mostly affected. And another one done by Amadio in 1989 basically showed that patients with a greater amount of malunion had a bigger proportion of patients that had developed arthritis. Treatment of scaphoid fractures. There's always the non-operative approach and there's the operative approach. We'll start off with non-operative. Patients that have acute fractures that are non-displaced and stable, that can be treated non-operatively with cast immobilization. And most of the time they will heal with good alignment in the cast. The union rate is around 90%. However, as the fracture becomes more proximal, the union time increases and the union rate decreases. So this should affect what we do with immobilization. So the more proximal the fracture, the more time the patient should be in a cast. And even the distal fracture, the distal third, should be treated in a cast for at least 8 weeks. I noticed a lot of the times people come out of the cast at 6 weeks, which really isn't appropriate. It should be a few weeks longer. Now, the type of cast is really the clinician's preference. This is the one that I've seen and used, which is a below elbow cast with a thumb spiker or the thumb immobilized. Some also use an above elbow cast with the thumb immobilized. The theory with this is that there have been cadaver studies where they've done an osteotomy of the scaphoid, and they found that even with a below elbow cast with the thumb immobilized, there's still movement at the fracture site with pronation and supination. So an above elbow cast will stop that. However, although cast immobilization generally has a good outcome, the result can result in delayed union, non or malunion stiffness, because they're in a cast for a number of weeks, and also the lost time from work or sports. So in these patients, there is also, I guess we can select our patients for operative management, where we can use percutaneous fixation, and this allows patients to go back to work earlier and get back to the sports. So people that are manual labourers and are dependent on their work for their income, we may offer this surgery for them. And some studies have shown that after 5 or 6 weeks, patients are back at work or back at doing sports. Indications for surgery. Fracture displacement more than 1 millimetre. If there's the presence of a humpback deformity, complex fractures, which are open fractures, fractures involving a dislocation, or scaphoid fracture with a distal radius fracture, which I believe we did one last week. Ali did one. Proximal pole fractures, patients that have presented late, so late diagnosis and late treatment. So patients that have presented, say, more than 4 weeks should be offered surgery. And also patient non-compliance, for example, smokers. The treatment principles are basically to realign the fracture fragments and to stabilize and to apply a stable fixation. The VOL approach is commonly used because it limits the injury to the blood supply, remembering that the dorsal artery supplied most of the proximal pole, or all of the proximal pole. However, the dorsal exposure can be useful for very proximal fractures. There are a variety of fixation devices available. K-wires can also be used, commonly used as joysticks to align the fragments until we place our definitive fixation. Bone grafts can be used, and the position of screw can be important, which I'll mention in a second. There are lots of different implant devices available: headed versus headless ones, cannulated or non-cannulated, fully versus partially threaded. The screw diameter can vary, and the method of applying compression can also vary. Here are just a few. This is the Herbert screw. It's a solid screw, so it's a non-cannulated one. This is a modification of the Herbert screw. This is the AccuTrack, which is a fully threaded one with a variable pitch. I believe this is what we have on the shelf. And this is a twin fix, which is two-part variable compression made by Stryker. These are just a few. This table here shows several studies that have been done which showed different approaches to fracture fixation, different implants used, and different fracture types. However, this is the main feature here, which showed that these studies here had a 100% union rate, and they were the ones that used headless screws, whereas the ones that had headed screws, they had a slightly lower union rate. Some of the principles of fixation. The rigidity of fixation, that's the most important factor in promoting healing of scaphoid fractures. And when we look at metal screws, absolute rigidity is directly proportional to the radius of the screw to the power of 4. So the wider the screw, the more rigid it is. In scaphoid fractures, the rigidity of the bone screw construct is also directly proportional to the surface area of bone contact onto the screw on each side of the fracture. Hence, the surface area of cancellous bone resisting bending is a function of the diameter of the screw and the length of the screw on each side of the fracture. Therefore, if we place a screw centrally in the bone, we can get a longer screw in there and a wider screw, hence something that's more rigid, as there's more screw on each side of the fracture. We can also, with greater compression, we may be able to speed up the healing process by promoting primary bone healing. And this can also increase the rigidity of the construct by interdigitation of the fracture fragments. Now, we also need to balance the benefit of having a rigid construct by using a large screw with the difficulty of getting that larger screw in the actual bone. Cannulated headless compression screws, I believe, are the preferred method. Cannulated because you can use guide wires to insert into the bone and get it into the correct or the ideal position before actually putting the screw in. Headless because you can bury the screw in the bone and aim for a central position. And compression because you can try and promote fracture healing by compressing the fracture. And again, central placement of the screw can be achieved by going in proximally at the radiocarpal joint or by going in distally at the scaphotrapezial joint. And here's a diagram showing central screw fixation. Here isn't quite central, and we can see how the threads on the screw don't engage into the bone. However, here they do. And again, here just some X-rays showing fracture of the scaphoid waist. Here they've inserted a cannulated screw. This looks like a fully threaded, might be an AccuTrack. And again, here at 8 weeks post ORIF with the fracture union. Post-operative management. Some use a cast, some don't. If we've got a rigid fixation, we don't necessarily need a cast, and we can aim for early controlled range of motion and use a removable splint just to protect it. Early controlled range of motion can provide early loading of the fracture, which may result with better fixate or maintain better fixation because it can prevent the disc-use osteopenia from occurring. Now, treatment of non-union. I'm only going to briefly mention some of the methods here. At the early stage of non-union, you can use a OrthoFracs with a bone graft. The inlay or the roost technique has been described, where they use cortical and cancellous bone, and they insert that into the fracture site. Can be from the distal radius of the iliac crest. A non-union with a humpback deformity can use a wedge or opening wedge interposition graft, described by Fisk. We can see here in the diagram how it's aimed to open up that angle and restore the length of the fracture and the angulation. Non-union with avascular necrosis of the proximal pole, vascularized bone graft can be used. The Zadenberg technique has been described, which is a diagram of this here, where they use a branch of the ulnar artery. And also the untreated chronic non-unions where they've developed SNAC. Well, there's a variety of treatment modalities here. Here in SNAC 1, stage 1, they've done a radial styloidectomy. They've done an OrthoFracs of the scaphoid with the insertion of bone graft. You can also excise the proximal or distal polar wall of the scaphoid. In this case here, in stage 2 SNAC, they've excised the distal pole. And in this diagram here, just showing a 4-corner fusion versus total wrist fusion. Again, what treatment option we use depends on the actual patient and how much of the carpus is involved. So as a summary, the scaphoid provides a very important structural role in the carpus. Its blood supply is very important as it has a retrograde blood supply, so fractures through the waist or the proximal pole will very likely result in a non-union or avascular necrosis. Undisplaced fractures can be treated with cast immobilization, whereas displaced or complex injuries need operative management. The displacement of the fracture will change the carpal kinematics, and without adequate treatment, patients may develop non-union, malunion, arthritis, or later on develop SNAC. That's the end.
Brilliant.